a great opportunity to present on this Stigma Indicators Monitoring Project, and this was a very exciting project, and this is one of our first times talking about it. So we're really interested to hear your responses to these type of data and this type of approach. So I'm presenting today on behalf of our team, Lauren Brenner and Max Hopwood and John DeWitt, but pay particular thanks to Eleanor Karma, who really did the heavy lifting on this project. So thank you, Eleanor. So we worked with a large advisory committee for this project, particularly representing the peak organisations in this space, as well as some key collaborators. I'll explain more about how the funding from the Australian Government Department of Health came about, and we'd also like to thank the community organisations that helped promote this survey, or these surveys actually. So, you know, we may all be familiar with this. Some definition and contextual information around stigma has long roots in the social science literature, with Goffman as one of the key classic texts describing and explaining stigma in some conceptual terms. But we also know that it's a social process, a process of power, where individuals or those who are seen to possess particular attributes or belong to particular groups are devalued by broader social groups and excluded in that process. We also know that stigma is associated with other harmful outcomes, as well as just being a bad thing in itself, that we can measure the associations of stigma with isolation, psychological distress, poor quality of life and poor physical health outcomes. So for those of us working in the health and social welfare space, it's an important thing to measure, to understand and intervene to reduce. In our area of communicable diseases, stigma has another important and interesting element to it, which is the fear of contagion around infectious diseases, the people being fearful that they might acquire it, and the negative attitudes that are associated with the transmission pathways around HIV and Hep C, which is unsafe sex or even promiscuous sex, and injecting practices, and all the social meanings and social freights that go with those practices. The literature also tells us that stigma can double up or triple up or layer up in a variety of different ways, where individuals are seen to possess multiple co-occurring stigmatised attributes, such as being infectious and having this perceived socially negative mode of transmission. And in the HIV space, we've had very strong statements from leaders in a variety of different areas, from the UN General Secretary saying stigma remains the single most important barrier to public action around HIV. Although that's almost 10 years ago, it's a theme repeated, unfortunately, because little movement has been made in international AIDS conferences and other meetings at that level of stigma being a persistent issue to deal with. So there are 5 national strategies around HIV, viral hepatitis and sexually transmissible infections, and all of them in their lifetimes have contained statements about stigma and discrimination. But in the most recent versions of these, there lacks a way in which to measure it. So other objectives, such as the one on the slide here about reducing the incidence of Hep C, have an indicator associated with them, where we're going to measure the annual incidence of Hep C in people who inject drugs. And that's the way by which we understand and measure the progress against the goals of the national strategy. We set a target and we have a measure and we track that measure over time. Now, each of these strategies contains this clear objective to eliminate the negative impact of stigma, discrimination and legal and human rights issues on people's health. But there hasn't been that attached indicator. Here's our blank slide. So here are the 5 colour-coordinated national strategies, each with a very similarly worded objective, but no indicator in any of them. And this was a gap that we all recognised, and we've been talking with the Commonwealth Department of Health for a long time about ways in which we could fill that gap of an indicator. And this is where the genesis of this project began. So 2 years ago, almost 2 years ago now, we were contracted by Australian Government Department of Health to develop that indicator of stigma among the priority groups of the national strategies. And we needed to be able to use that indicator across gay and other men of sex with men, people who inject drugs, people with HIV, people living with Hep B or Hep C, and people who engage in sex work. And we're also asked to develop a related indicator for health professionals and the general population, and that was to be a measure of expressed stigma, such as negative or discriminatory treatment of patients. So, okay, an indicator is a very specific beast. It is usually one number. How many tests have been performed? How many people have acquired Hep C? How many people have gone on to treatment in the last period of time? Stigma is really difficult to reduce to one number because it is a complex social, societal power construct. It can include all these things and many things, other things that I didn't have space to list on the slide. Anticipation, perception, actual experience of being treated differently. It can occur in a range of relationships and settings, interpersonally, with the healthcare system, in criminal justice, in housing, and many other contexts that we can imagine. Financial systems has become an interesting one around the sex worker work we've been doing. How PayPal interacts with sex workers is a very interesting aspect of stigma. So how do we put all of these social and political, interpersonal beings into one measure as a stigma indicator? A few other things to consider. Enacted stigma. Very difficult to measure the actual moment of discrimination or the occurrence of discrimination. Very difficult to measure when we're using our available measurement tools. Very hard to ask people, do they do this to other people? Social desirability biases and so on influence whether or not people are going to answer, yes, of course I discriminate against these people. And for people living with bloodborne viruses and STIs, there is this issue of multiple layers of stigma, not just the infection, but perhaps the practices that are associated with those infections in the societal and epidemiological view. So, you know, we are trying to capture all this stuff in one number. So I really want you to hold that in your minds as we go through, because I'm sure you're going to be going, but this isn't there, and that isn't there, and this isn't there. And we know, and we struggled with trying to work to this one number measurement all the way through. So this is it, a big reveal, ta-da! So this is what we asked of people who are living with HIV and Hep C, men have sex with men, and people who inject drugs. So in the last 12 months, to what extent have you experienced stigma or discrimination, with some examples of what that might be, in relation to your, and then we have a list of attributes down the left-hand side: sexual orientation, use of drugs for injecting, various bloodborne virus status, sex work, and other. And then we ask people to indicate the frequency from never to always, and with a not applicable box on the side. So importantly, this is also framed with a time frame in the last 12 months, so that we can repeat this measure and see if we've got change. What proportion of people are expressing yes to this question now, in 2 years' time, in 5 years' time, 10 years' time. So we can track the expression of stigma over time. Hello, come on in. So that's it. All that work of trying to represent a really complex thing, there it is. And we'll show you the data and some of its limitations and some of the things it tells us in a moment. Our big advisory group also asked us to measure a few other things. So they asked us to add in these two other questions, again with that in the last 12 months time frame. To what extent do you agree that the following occurred? And because this was funded by the Department of Health, they asked for this first question, that health workers treated me negatively or differently to other people. And the second question, people didn't want to have sex or an intimate relationship with me, was really inspired by the understandings from our colleagues in the HIV and gay men sector. So we added these two items as well, again using the same response scales. So then we had to do this work of mirroring what we would ask health workers to report. And again, you know, this is a very terrifically difficult thing, asking health workers to reveal to us their practices. So we tried to introduce it in with some language that might allow people to say some things. So it's a longer introduction. We may judge or regard people negatively at times because of different cultural background, lifestyle, or health issues. The following questions ask about whether you have ever done this to others, and we understand that may be difficult for you to answer. Please be honest. in your responses, they will be kept anonymous and confidential. In the last 12 months, that time period again, do you feel that you may have discriminated against patients or clients because of their, then the list of attributes is repeated and the time frame is the same. And then we also thought it very important to ask that bit at the bottom, have you felt stigmatised because of the area in which you work? So we were trying to give health workers the opportunity to say it's not all one way. We have issues in our workplaces as well. So we used new and existing surveys. So for people living with HIV, this is phase 1, Stigma 1. I'll tell you about Stigma 2 at the end. Stigma 1, we ran an online survey of people living with HIV. We also were very kindly supported by the Kirby Institute Garrett Prestige's new survey telling about disclosure to incorporate the indicator into that survey of men who have sex with men. We also ran a new online survey targeting people living with hepatitis C and people who inject drugs. And also we were very kindly supported by the Kirby Institute through Lisa Ma's program to include the indicator in the Australian NSP survey. And then we also ran a survey of health workers using the ASHM contact list. And ASHM is the Australasian Society for HIV and Hepatitis Medicine. So it maintains a database of a few hundred people working or interested in that space. I'm going to focus today, because of time, on the people living with focus and not the health workers. So this is a new indicator, so we wanted to do some validation work. So in the new surveys, we included some other measures, including descriptions of who people had disclosed various things to, issues of whether they've had treatment, what substances they might use, social support, mental health, and some additional stigma measures, internalised and vicarious stigma. So we could see if our indicator is working with those kinds of things. We couldn't include those things in the existing surveys because they were already full. They didn't want us to add in our pages and pages of additional items. It's always, I don't know, what's the problem? I know. So we wanted to be able to do that validation work. So this is the new sample, our sample of people living with HIV, an online sample. So we recruited about 180 people, with a mean age of 50. All states and territories were represented. Most were men, most identified as gay, most were born in Australia. Mean time living with HIV was 16 years. 61% reporting a lifetime mental health diagnosis. Almost everybody on ART treatments. Almost everybody reporting an undetectable viral load. And about a quarter reporting that they're living with HIV or treatment symptoms. I'm going to skip over that in the interest of time. So here's our data. Not sure if I'm going to get a, here we go. So, ooh. There we go, sorry, I leant on something. What we need to be looking at is the areas to the right of the red. So the blue and the reds are the not applicables and the never. So the areas to the right of the red are those who are experiencing any stigma. So this is people living with HIV. To what extent in the last 12 months have you experienced stigma discrimination in relation to sexual orientation? So we can see, I've written these numbers down because I can't do maths on the run. 59% indicating some stigma in the last 12 months. In relation to injecting drug use, 52% to the right of the red. And for living with HIV, 74% experiencing some levels of stigma in the last 12 months. This is giving us an indication that the indicator is working in the ways in which we want it to, that we're getting this kind of representation on the HIV attribute when we are targeting a sample of people living with HIV. What I'm going to come back to later is the issues around the not applicables and the nevers. They're a little bit hard to interpret, and we've got some recommendations of how we might do it differently in next rounds. So on those additional two items, have health workers treated me negatively or differently? We have 51% saying yes, some. And in relation to people who didn't want to have sex or an intimate relationship, 60% to the right of the red. How's that? Should we just pause for a moment, make sure everyone's okay with this, if there's any issues to raise, or keep going? Because you'll see this is a pattern of results I'm going to keep reporting. So then we did do some validation work. So was our indicator working in the ways it should be? And for the HIV group, yes, it worked quite nicely. That our indicator data was significantly correlated with measures of HIV treatment-related stigma, experiences of discrimination, vicarious stigma, internalized stigma, and the indicator around sexual orientation. So they are all the kinds of relationships we would expect. That this measure of stigma correlates very nicely with other measures of stigma. It also was correlated with greater psychological distress, lower personal well-being, and reduced social support. That's, good to know, not good on the individual personal level, and also not new. We know that from the literature. So it's good to see our data behaving in the way that we would expect it to behave, but not new findings. More of the validation work. So here is the data from the Kirby project, Men Have Sex with Men, the disclosure project. So we've got, in some of the categories before, we had so few people reporting hepatitis C that we didn't feel it was appropriate to report that data. But we've got larger numbers here in Hep B, Hep C, and in sex work that we can report it. So again, it's looking to the right of the red to indicate people who are experiencing any of this in the last 12 months. So in the first row about sexual orientation, and again, this is a survey of men living with, men have sex with men, so different to the living with HIV sample before. 65% here. Only 12 on the injecting drug use. HIV, 73%. Hepatitis C, very few, 4 and 4 for Hep B and Hep C. And sex work, 23%. Now this is where we start to worry about what the blue and the reds mean. Because, for example, we don't know whether people were answering never in red as really as not applicable. And that's the work we want to do in tidying that stuff up in Stigma 2, so we get a clearer, less messy picture. But nonetheless, we can see this kind of indicator behaving in the way that we want to, that we see greater representation of experience of stigma around sexual orientation and HIV on a sample of men of sex with men. This is the kind of stuff we would want to see. And on that MSM survey, again, these two additional indicators, we see 33% saying some experience of stigma in the healthcare worker setting, and 82% about people not wanting having a sexual relationship with me in the last 12 months, which is really kind of high. Now, our people living with Hep C, people who inject drugs sample. This is a new sample again an online survey, 165 people, mean age of 50, again all states and territories represented. Males are about 1/3, and this is something that we really want to interrogate, and our advisory committee asked us to look very closely at, because that's not the usual in samples of people living with Hep C and people who inject drugs. It's usually the other way around, 2/3 men, 1/3 women, not 2/3 women, 1/3 men. So we've got to be careful about how we interpret these data. Most born in Australia, again unusual for the kind of samples we've seen before, almost 3/4 with greater than high school education, only 1/4 on government benefits or unemployed, again not quite usual in the kinds of samples we've collected before. Interestingly though, still lifetime mental health diagnosis of 63%, 83% reporting lifetime injecting drug use, 35% in the past month. 100% aware of DAA treatments. So this bit of data and the next one with 3/4 having current or previous treatment, indicates this is a highly treatment engaged sample. So an interesting sample, one that we shouldn't dismiss, but we should really know the characterisations of it to understand the stigma data that we'll see coming up. Of the 1/4 of people who haven't had treatment, we see about 1/3 with no plans to have treatment and another 15% who are undecided. So that, I think, is really interesting about the talk around hepatitis C of the further work we've got to do to engage people in treatment possibilities for them. Right, oops, wrong. Here we go. Here's our indicator. So here we've been able to present these 3 attributes: sexual orientation, injecting drug use, and hepatitis C. We didn't have enough people reporting hepatitis B and sex work to have a meaningful representation here. So again, looking to the right of the red, I'll get my numbers straight. We have 28% indicating any stigma in relation to sexual orientation in the last 12 months. 58% reporting any stigma in relation to injecting drug use in the last 12 months. And 56% reporting any stigma in relation to hepatitis C in the last 12 months. Now, our advisory committee pored over these data and we're a little bit worried about them. And I think that reflects the demographics that we saw before, a highly treatment engaged sample who may no longer be living with hepatitis C, and only a small proportion, about 1/3, who'd had last month injecting drug use. So this is a sample, we shouldn't discount it, but it is its own sample and we need to understand what these data mean. However, it'll be interesting when I show you in a moment the data from the Australian NSP survey to compare what we see. So in the additional indicator, health workers have treated me negatively or differently in the last 12 months. 56% reporting some stigma. 22% reporting people didn't want to have sex with me. And I think that's good. That's the way we would expect this indicator to happen, to behave. We saw a lot larger proportion here for the other samples of people who live with HIV and men have sex with men. That's nice to see our indicator behaving in the way we would expect. Again, some further validation work. And when we did that validation with this, we saw some good stuff happening, but not exactly all the things we were expecting to happen in the validation work. So we did see our Hep C status indicator significantly correlated with measures of Hep C related discrimination, Hep C related vicarious stigma, injecting related vicarious stigma, and the indicator around injecting drug use. The injecting drug use indicator correlated with injecting related discrimination, injecting related vicarious stigma, psychological distress and personal wellbeing. So we're heading in the right direction with this validation work. Now turning to the Australian Needle and Syringe Program survey sample. So again, larger numbers, so we're able to present across the full range of attributes. So again, the key is to look to the right of the red. So we have 20% indicating stigma, any stigma in the last 12 months related to sexual orientation. 64% in relation to injecting drug use. Very small around HIV, again indicating our problems with the not applicable and nevers. I think most of those are not applicables rather than nevers. Hepatitis C, 28%. Hepatitis B, small numbers here, 10 indicating anything more than never. 10 for sex work and 25% in the other category. So for example, around the sex work, we had 1,800 people finishing this indicator, but we're pretty sure that 58% of this sample were not engaged in sex work. That seems too high. So I think there's an issue around we need to rework that never not applicable issue in future. We had one of the additional indicators in this sample, which is health workers treated me differently. And we have 41% indicating anything more than never. Compare that to our previous sample of people with Hep C and drug use was 56%. So we have a lower proportion reporting issues with health workers in the NSP survey than in our online survey. So I wanted to leave quite a lot of time for discussion and interrogation of these data, because we're still working it through. So I wanted to tell you about a few of the things that we want to do for Stigma 2, which has been funded by, again, the Commonwealth Department of Health. So as I've mentioned along the way through, we want to tidy up some of this data messiness. And so we're going to split the attribute rather than one big table. We're going to ask each time, do you live with HIV? Yes, no. If yes, in the last 12 months, have you experienced? So we absolutely know. We get away from that not applicable option. We were trying to make it nice and neat on the page by having one table of questions, but it created problems for us in understanding the data. So there's going to be a major change to the actual format of the question. In Stigma 2, we've been asked to do some work around people living with Hep B, and we felt it important to do some foundational qualitative work before we jumped into a survey, because we really need to understand the kinds of issues, the kinds of language to put around this indicator for people with Hep B across particularly the main community groups affected by hepatitis B. We've been asked to replicate our express stigma questions in a survey of the general public. So we have included that indicator and some other questions in a survey called the Australian Survey of Social Attitudes, and that runs over 3 waves. So it's a nationally representative sample of people aged 18 and above. So we'll have the data from that early next year. In Stigma 1, we had a terrific partnership with Scarlet Alliance where we did some focus groups co-moderated with me and workers from Scarlet Alliance, and we want to use that data to turn into an appropriate survey of sex workers in Australia and use the focus group processes as a foundation for appropriate recruitment as well. So that work has been really terrific and really rich in the kinds of information we've got and what we can build into a survey next. The Commonwealth has also asked us to think about STI stigma, and I think that is, again, a very different beast compared to the other things we were looking at. STIs are easily treatable if they're detected, that just at different age groups, general population, young people, and the other groups in the priority population. So we are still working through the ways in which we might do that, but we've added STIs into our measure from the general population. We've also been talking to people running youth surveys about how to include this in their surveys. We also need to work to extend how we're recruiting people living with Hep C and people who use drugs into the online survey space, and we'll work with the community organisations to enhance the ways in which we can get a different sample than we recruited this time, as we may not always have access into the Australian NSP survey, particularly if we change the format of the question and make it longer on the page. But this is the first time this has been done anywhere. So we're really happy to learn and to think differently, and each of our national strategies includes this goal to reduce stigma and discrimination. Measuring it is the first step to be able to demonstrate that we're achieving some kind of change. So we're really happy to be a part of that and contributing in this space. There's our long story. Really happy to hear your thoughts and reflections on this and see if we can answer any questions. So I know Lisa, we've got a microphone because we were recording. Anybody want to start? For those who came in late, I might just flick back, whoops, that's the wrong way, to what the indicator looks like, in case that you missed that on the way through.
Thanks, Carla.
No, it's not on, it's just recording. It's not projecting, it's just recording.
Thank you, Carla. Very interesting work. I agree about you're not applicable versus you never, and you're going to clean up a lot of that messiness with your proposed solution, I wonder, I'm sure I'm not telling you anything you haven't thought about yourself, I wonder what you're going to do where to capture people who've not experienced stigma because they have not told anybody, because they're concerned about stigma, so they could well answer never, when in actual fact, you know, it's a bit of a different scenario to everybody knows I've got Hep C and they're all cool with it.
Yeah. So what I didn't have time to present is this disclosure data, where we did ask people, you know, I didn't have time to present it, but now I'm presenting it now, so, you know, what am I talking about? Where we did ask people, and you see very interesting patterns across the HIV and Hep C and drug use, where people make very clear decisions about who they want to tell. So in this, again, we're looking at the blue is I didn't tell anybody. So higher proportions of people not telling anybody at work colleagues and employers, and lower rates of never among health workers, sexual partners, friends, etc.
I'm going to go here. Thanks. Sorry, I'm swapping between glasses. I'm Barbara. Thanks very much. Sorry for coming in late. Look, it's really great work you're doing, so congratulations on that. And I think it's great you're collaborating with Scarlet Alliance, and I just wanted to make a sort of a query there. I just thought one of your statistics, I may have interpreted it wrongly, just seems that only 10% of people who identify as sex workers experience stigma seems very low, and also your negligible sample where you weren't able to include sex workers. I just wanted to comment that, you know, just sort of in the next round it may be good to look at non-disclosure, fear of disclosure, and also what's included as sex work, like opportunistic sex, trading for goods and services, and, you know, what is identified as sex work, also, like former and current. But, you know, great work. Thanks.
Yeah, I think what that data tells us, more than anything else, is that we need a proper survey that targets people who would respond to an invitation to comment about sex work and stigma. Because I think our not applicables are messing up the picture there, and it's not what we want to see.
Yeah, thanks, Carla. Could I go back to the non-applicables and talking about people who have multiple stigmas?
Yeah.
And how maybe you're going to deal with that, because that can be a movable feast. I've got a trifecta, and I'll disclose maybe that I'm HIV positive in one situation, whereas I wouldn't say that I was an injecting drug user in a situation where I told somebody I was already a sex worker and HIV positive.
Yeah.
But that situation might be reversed somewhere else.
Yeah. So this is the problem with an indicator, because it reduces all of that really important contextual stuff to one number. We will, in the revised version where we say, do you live with HIV? Yes, no. Have you experienced stigma? Do you live with Hep C? Yes, no. And all the way down. We'll be able to look at that with much more clarity than we can at the moment. So I think that would be a really interesting analysis to look at multiplicities of stigma, but we won't get the context because we're producing an indicator. But we've got all of that from the qualitative data with Scarlet in particular. And Eleanor, did you want to add?
I just want to clarify that we were actually able to ask, thank you, we were actually able to ask people, you know, have you engaged in sex work? Do you have HIV for each of those surveys? But where we couldn't do that, where those not applicables particularly become a problem, were the existing surveys where we didn't have any control over what extra questions were included. So sort of the Australian NSP survey and the survey of men who have sex with men, that's where that becomes a problem, where we don't know how many have reported hepatitis B in particular, but also Hep C in some circumstances as well.
Yeah, so we hope we can fix that.
Again, thank you. That was really interesting research. I'm a bit curious about what some of the most common answers you got for other were.
I told you that'd come up, Eleanor.
Yeah, so I wrote it down in advance. So we had a huge range, and I think the biggest range was probably for the Australian NSP survey, because that's where most people actually responded. So some of the really common stuff we got was age, gender diversity, and female gender in particularly, race, Aboriginal background, mental health, criminal history, and religion. So those were pretty common. But we even had things like fitness and appearance, and there was just a huge range. Yeah.
Thank you. It's so good to see this being presented after hearing about it for a while. Just on that splitting question of how to structure it to get rid of the never problem.
Yeah.
So by saying, are you a person living with whatever, and then only answering the question, that doesn't capture where stigma might be experienced if someone assumes, based on another attribute, that someone might be living with Hep C or might have injected. So particularly the relationship, I'm thinking about the kind of co-stigma relationships. And again, indicator you can't do everything.
Yeah.
But in some of the stigma work I was doing kind of late last year, that was something that came up a lot, that there was an assumption that if someone was living with Hep C, then they must also inject drugs, and therefore they'd experienced discrimination from whoever based on that assumption, even though that may or may not have been true.
Yeah.
So splitting it doesn't capture the assumed stigma.
It doesn't. You're right.
Yeah.
I'm not sure I've got an easy answer to that, looking at my colleagues around the room.
We actually did talk about that a lot, especially when we were designing the indicator. It was really complicated when we actually came to analysing the results, because even people who said that they had Hep C reported not applicable for stigma. And so it wasn't just like a never. What does that mean? Like, we have no idea. Yeah, and so I think that because we're particularly conscious of the relationship between injecting drug use and Hep C, we would still include questions around both. But when it comes to interpretation, sometimes it's just, we're really not sure what they're trying to say. And I suppose that's a limitation of quantitative work, though.
Thank you.
Hi.
That was really interesting. And I know that indicators can be really difficult to work with. What I'm interested in is that first one, which is sexual orientation.
Yeah.
And seeing there that some people have said not applicable to sexual orientation.
Where
and
everybody
sort of
has
how
one.
that is
right?
being interpreted. Given
Or
that
many.
everyone
Yeah.
has a sexual orientation, how do you not have one?
Yeah.
And curious as to how that has then been modified in stigma too, and whether you're breaking it up and trying to get people to label their sexual orientation, and are they labeling it with the next 12 months or
So you want to do that?
That's actually, I know, right? So it's kind of funny because while Carla was presenting, I was sitting here writing notes about that because I thought maybe someone would ask. So we did break it down by sexual orientation for the people living with HIV group in particular. Some of the orientation groups, the numbers are too small to look at. So bisexual was one of them. We did look at, so for people living with HIV who identified as gay, they reported, 68% reported sexual orientation stigma. So 68% of people living with HIV who are gay reported that they experienced that in relation to their orientation. And that was actually the same among the group of men who have sex with men. So we can break that down because we do ask about sexual orientation, but some of the groups are just too small to look at. But even in the survey of men who have sex with men, we actually had 2% who reported not applicable. So they were gay, but they reported that sexual orientation stigma was not applicable to them. So again, like, what are they trying to say? But yeah.
Thanks again for all of this. I think all of us probably have 1,000,001 suggestions and
Happy to hear them.
questions, but I think it's because it's such a huge topic
Yeah.
and probably there's not enough that's been done to actually look at it. So I think that's why all of us are like,
Yeah.
yes, something. But I guess one of the things I would be interested in, and it may well be this is beyond the scope of it anyway, but is around perceptions of stigma and the impact on behaviour.
Right.
So particularly because of this non-applicable never thing, but are there people that they might not have experienced stigma, but their fear of experiencing stigma, has that impacted on their behaviour in some way? And I guess another thing related to that, which you actually just touched on, which kind of actually answered my question, but I am also interested in how that then also affects things like sexual orientation. So for your MSM, the fear of stigma about sexuality, is that even connected to why they were thinking themselves as MSM and not gay, for instance? So things around that. And then I guess just one point as well, but again, this is, breaking down data too much, and indicators might not be able to measure it, but it might have been a suggestion around HIV rather than necessarily has HIV or not, has HIV or don't know. Like,
yeah, right.
playing
Yeah,
around
I'm
more
sure we have that measure of HIV.
So,
Do you live with HIV?
so for this,
Oh, yeah.
thank
Got that
you.
again.
For the survey of people living with HIV, they had to report whether they knew. So people who said that they didn't have HIV were excluded from this particular survey. But I think that was because it was the brief from the Commonwealth was to have a sample of people living with HIV, but also because of where we were recruiting this group from was, from NAPWA and AFAO. So yeah, that's that group.
On the fear of.
It's probably beyond the scope of the indicator.
Did we measure vicarious stigma?
Yeah, we did look at whether people living with HIV reported that other people living with HIV have told them about being rejected by friends or by family. So, and to look at whether that was associated with them experiencing more stigma. So it was. So the extent that, if you have a group of friends who also live with HIV and they're telling you, I'm copying so much crap in relation to my HIV, that also impacts on their own experiences of stigma as well. So that there was a relationship with that. But I mean, there is work around fear and anticipation of stigma. There's actually quite a lot of work about how it's not just actual experiences, that a lot of it is to do with fear and anticipation, and that is highly correlated with negative health outcomes. So yeah, there's quite a lot of work, particularly in the HIV field, in relation to that.
Yeah. So we made choices about not needing to replicate stuff that was already known, and really honing in on what was going to give us an idea of whether or not this indicator was working. Yeah. Which we probably won't. We might do in Stigma 2 just because we'll have changed the measure, but eventually we'll stop that and we'll just focus in on the indicator if we are refunded to do it.
Hi, sorry we're late. Trams.
Yeah.
Sorry. Just on Hep C HIV co-infection, I think Cameron kind of related to it a little bit. Is in my work, I'll often get people who will disclose their HIV way before their Hep C. So that would be really interesting to look at if you can get, obviously, the numbers. The other thing that came to mind is if you're looking at STIs, maybe stratify the STIs and look at the different levels of stigma associated with each of the STIs. We'll do that. So we do have measures of whether or not people are living with the variety of infections, but we haven't. I'm not sure we have the numbers to. Excuse me.
But I mean, that's because, the people that we're recruiting have been people living with other infections. And so if we're targeting we kind of have this issue of how do you recruit a big sample of people living with STIs? That is just like mammoth. That's a huge group, and we're kind of wondering where to start on that. So we've been consulting with the Commonwealth on ways that we can target specific groups, without making it just too big a task.
And is it people currently living with an STI or who've ever had an STI, or what does that mean? What's the priority for the Commonwealth in that measure? Not there yet.
I think when we're looking at multiple stigmas and why we'll disclose one over another, I think that we've found in the work that we do, it's also about not only the fear of stigma and discrimination, but it's tied up with sex. It's more okay to have HIV than Hep C and injecting drug use around sexuality and illicitness. So I think that plays a part in why we'll disclose one over another in certain contexts.
The saliency of each in the variety of places where you might want to or have to disclose.
I'm aware of the time, and I don't think we want to be late. Make Carla late for the airport. Is there a last burning question or two?
I just wanted to query your indicator and your comment regarding mental health and what you mean by lifetime mental health diagnosis, and of course, people who are diagnosed with mental health issues experience another type of stigma, and the differentiation between people who self-identify with mental health issues and people who've had that imposed on them, and it masks other issues and is symptomatic of living in a stigmatised community.
I totally agree, but I don't think we've got the ability to tease out that second point of being diagnosed versus identifying as. The lifetime was, have you ever been diagnosed with a mental health issue? Yeah. So, we know that it's prevalent in the general community, but 63% is rather high. And it's about the same for the different samples. And so when we, a range of things we could do is look at if people who report a mental health diagnosis report higher rates of stigma on the indicator. But we're not there yet.
Okay, I think that's about it. That was absolutely fascinating.
And again, it is a work in progress. So we're very happy to hear other thoughts that come to you over time. So please be in touch.
Please join me in thanking Carla.
And the rest of the team.